All right, welcome to our new episode of GNT. Today we have the honor to have a guest here. He's our used to be our trauma director. Now he's actually our boss here. His name is Dr. Joe Ibrahim. He's a trauma surgeon. He actually did his trauma fellowship at Orlando Health. At the time when he did it, I was actually a resident. I think I was a third year or something like that. But it was a long time ago. I was a first year. Oh my gosh.
You were an intern.
Oh my gosh. So we know each other for a long time, and progressively has taken the trauma program into a different direction, into a better direction, should I say. And then now he's the head of our medical group surgery chairman. Um, Dr. Gonna take over. You speak a little bit more about Dr. Ibrahim.
Yeah. First of all, do I have to refer to Dr. Ibrahim as chairman in chief, or how do we address
Almighty,
him?
Almighty.
I see. So, Dr. Ibrahim, you here as trauma surgeon, I think you saw everybody knows at this point that ORMC is a level 1 trauma center, and you guys do a lot of cutting edge trauma cases and other like also acute care cases as well. So nowadays there's quite a relation between, and there's quite a bit of studies between morbidity and mortality and obesity when related to trauma and injuries. Can you tell us a little bit more about those and what your experience has taught you?
Sure. Yeah. First of all, thanks for having me on here, guys. It's been fun to watch your episodes, and I'm honored to be here with you guys. You guys do incredible work in bariatrics, world renowned. I'm just a regional guy. You guys are worldwide, as Pitbull would say. So very honored to be here with you guys. But yeah, I mean, as we all know, obesity impacts health in so many different ways, and trauma is no exception. Um, I was surprised when I looked at the data. It was very difficult to draw a direct correlation between mortality and obesity, which I honestly was surprised because, anecdotally, we all feel like, yeah, it absolutely impacts mortality. I will say it indirectly impacts mortality, and I'll talk more about that. If you look at the studies, the majority of them look at obviously mortality, but then, okay, what are the complications? What are the problems people have typically with obesity? And it's exactly what you would expect. The number one thing is pulmonary issues, lung breathing issues. And if you can't breathe, you can't live. So as we all know, people with even just abdominal surgery, pulmonary complications are at the paramount of one of the complications they can have after abdominal surgery, because if you hurt, you don't breathe, you don't do those things, and especially if you have more weight on you, it is even harder just from a mechanical standpoint to just breathe easily. You add just one or two rib fractures on top of that, on top of any other injuries, now you're really struggling to breathe, and then you add the obesity on top of that. So you look at the studies, there is a direct correlation between increased days on a ventilator, which is something we in medicine look at, increased ICU stay, which the longer you're in the ICU, the longer the chance that something bad's going to happen, whether it's pneumonia, bloodstream infection, pressure wound from being on your backside so long. So all those things are sequela or results of obesity. And then, as Ghanem and I were talking beforehand, even just the ability to provide care in a morbid obese patient, whether it's, especially when you're talking about blunt trauma, meaning somebody's in a car crash, somebody that got hit by a car, or our most common trauma admission, which is just a fall, right? Just somebody that falls, they have significant trauma. And then you add the obesity on top of that, and they can have, like I said, rib fractures, pelvic fractures, and now they have to overcome the mechanics of the breathing that are really worsened by this obesity.
So it's kind
that's
of
interesting.
Sorry, go ahead. Yeah.
Go ahead. Finish.
So it's something that I kind of contrast and compare to COVID infections, right? We know that those who get COVID infections and suffer from obesity at the same time are much more likely to suffer from long-term sequelae from the virus. And it's nothing really that is directly related, as I always say to the patients, to that specific virus, best of my knowledge. But rather, it's just that when you get any infection and you suffer from obesity, like you put it very simply and nicely, it is very hard to breathe. And as a result, you have all of that extra weight that it hinders your expansion of the lungs. And then if you, God forbid, end up being on a ventilator, it's much hard to get off of that ventilator, longer stay at the ICU, pressure sores, so on and so forth. The other thing is basically if you end up needing surgery for an acute cause whatsoever, that being trauma or anything else, it is much harder to operate on an obese patient, especially for those trauma cases that are done open, as opposed to the robotic techniques that we use, for example, for bariatric surgery. And that makes the surgery much more complex, much harder to perform, and as a result, that can impact the outcomes as well. Am I correct?
No question. Yeah, because the majority of our trauma surgeries, they're not laparoscopic, right? They have to be open because it's an emergent situation. Their blood pressure is low. They're having active bleeding. And so the quickest access for us is to make sure we check everything, meaning all the organs, bowel, mesentery, all those important things, all those important structures. The best way to gain access to that is a large incision. Well, as you pointed out, somebody that's already obese, the mechanic, just the sheer ability to get into that abdomen is difficult. And then, the recovery, again, they have to overcome the breathing mechanics, which we've hit on. They have an increased risk for wound infections, right? Because now you've got all this adipose tissue, all this fatty tissue that has very poor blood flow, as you guys know. And now those wounds are very difficult to heal, even with, we use a lot of things. We're using more negative pressure wound therapy devices now. Even if we get the wound closed, we're using those on top to help decrease that tension or that pressure on those wounds, because when they're obese and you have that tension pulling on the sides, on each side, it's pulling away from the midline. Now you're having increased risk of a wound complication.
Mm-hmm. The other thing interesting, I've noticed, I'm going to call Joey because I know you for so long.
Please do.
So, Joey, one thing I've noticed, and pretty rarely we go to the ER to see any patients, any consults, patients that have surgeries done somewhere else and so forth. But I've noticed that in general, the patient population that's presented to the ER, and I'm assuming also for other practices, the average weight of BMI has gone up since me and you were residents and Dr. Ghanem was residents too, right? And I've noticed too that the changes that had to occur with not just the surgical techniques or the approach or in terms of ancillary services like CT scanners, X-ray machines, right? Different type of ventilator mechanisms that we never used before. Now it become a little bit more use friendly, just because, like you said, the necessity of excess weight and the rib traumas and so forth in terms of the lung injury, right? So it's not that simple to take care of patients. They are overweight, obese, trauma patients, right? So, which sometimes people think, oh, I'm a healthy overweight or I'm a healthy obese patient. That's the unicorn, right? That doesn't exist, right? So what I try to tell them sometimes is, if I go 100 miles an hour and I hit the wall, right, and someone that's 3 times my weight goes 100 miles an hour and hit the wall, the blunt force is going to be much higher, right? Just because of the weight itself. So the injury is going to be much higher, right? So those patients that we see, or that you guys see, that on the trauma bay, usually they have a much more severity score, should I say, much higher,
Absolutely.
right? Because of the weight itself, right?
Absolutely.
But one question. Go ahead.
No, I was going to say, you're making me dig way back into physics, but force equals mass times acceleration, right? Larger the mass, and larger the mass, the bigger the force. So,
right.
You're hitting it on the head. But yeah, continue.
Yeah. So the other thing is, and correct if I'm wrong, do you think by having a bariatric unit or service at your institution, do you think that your hospital is much better fit to take care of a trauma patient that comes with a higher BMI just because already all the things that we have for our own patients?
No question. No question. I mean, you hit it. Number one, first and foremost, the imaging capabilities. I mean, we get patients sent in all the time from other centers that they may not fit, what we call trauma alert criteria. And for those of you that don't know what that means that there are state criteria that EMS guides EMS to tell them, do they take them to a trauma center versus they can take them to the closest emergency room. And so a lot of places, a lot of times they don't necessarily meet the heart rate or blood pressure or those kind of things, the criteria that require them to bring them to a trauma center. So they'll take them to the closest ER, but then they can't complete the workup because they don't have a CT scanner that will fit a large person. So that's the step number one. And then again, to your point, now you get them admitted whether maybe they have 2 rib fractures. Doesn't sound like a lot, but it can be a lot depending on the individual. Now you have to have the nursing expertise to know what to look for, to work on turning. You have to have the team that can get those patients up and move them because these patients have increased risk for pressure wounds, as we've talked about. They even have increased risk depending on if they were if it was a motor vehicle crash or if they were a fall and they were on the ground for a long time. They have additional risk factors that put them at risk for other really problematic things such as rhabdomyolysis or breakdown of tissue that then leads them to problems with kidney failure and other things. So if you don't have that experience with the morbidly obese, there are a lot of things that A, you won't even know to look for, and B, your staff or your team, not just your physicians, but as you mentioned, your ancillary staff, nursing, respiratory care, even your techs that are working on moving, they are not going to have that comfort level. So it absolutely increases our ability to take care of more patients by having that experience with the obese population, by having your program.
Right. And it's like Dr. T also touched about beforehand, and because I also see this often and hear this often. They tell you, oh, I am obese, but I'm completely healthy. I'm fine. I feel well. Tell them you feel well, but up until you don't, right? And this is almost often seen, exactly, the unicorn, often seen with trauma as well, because, and I show this to some patients as well, they start having some minimal event of dehydration, all of a sudden their kidney function jumps up. And I tell them, this shows you that you've had very little reserve. Any insult that if I just didn't drink for one day a little bit less, I would have been able to handle that very easily. But your kidney function has been basically working on reserve for quite a while. It looks okay, but any insult to that really puts it out of the normal range and values to basically kidney failure or so. And trauma is one of those, right? So they feel okay, they get involved in a car accident, like you mentioned, maybe 2 rib fractures, something that somebody else would have handled fairly with ease or without much complications or sequelae, but then all of a sudden everything becomes complex and they have pneumonia as a result. And if they get on the ventilator, they need a tracheostomy and their neck is much shorter and it's much harder to perform that procedure and it becomes riskier and triggers, basically opens up this Pandora's box.
Or sometimes you don't have devices that won't be able to fit, right? I remember an issue we had that they asked us to do a tracheostomy on an obese patient, and we didn't have long enough trach. We had to wait for the trachs to come in, right? So this is very interesting, right? I mean, what we're seeing, and I wonder, by looking the trauma database, we don't have access. If your see our database for the best equipped, which is our database for bariatrics, we're able to break it down by BMI and so forth. I don't know if you guys have that capability, because it'd be interesting to see, right? How long these patients are staying in ICU, how long is the care, how long is the severity score, right? The trauma injuries and so forth. And then that'll be a very interesting study to look at it, right?
Right.
To compare.
No question.
right? Uh,
I was just gonna say
it's in
we
go
do
ahead.
have those capabilities. I mean, it's in our database. And the studies I looked at just that, looked at the obesity, the injury severity scores. And again, most of them found that oddly enough, their injury severity scores were not much higher, but their complications rate were. So that just tells you the impact of the obesity, that these people should not be that sick, but they're having longer lengths of stay, longer times in the hospital. Not a direct result with increased mortality, but if you add that increased infection rate, increased complication rate, those people are going to have an increased mortality, right? So they're actually a correlation.
So one of the complications that so in bariatric before my time and before Ghana's time, they used to be done open surgeries, right? Way back when. And the incidence of hernias was like pretty much almost 100% of the time on those patients, right? So we still see some of those patients that had bariatric surgery in the past. They come here, all of them want a revision, and all of them have hernias, right? So I'm pretty sure that those patients that you guys have to take to surgery and open them up, right? Rightly so, to control whatever issue they are having. I'm pretty sure they have a high incidence of hernia too, just because, like you said, they're on a ventilator. Sometimes they have to take medications to keep the blood pressure up, dehydrations, etc., 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 right? With all the other issues that they have, it compiled to not healing the wound well. So, how do you guys deal with that? Because I know you guys are part of the Orlando Health Hernia Center, Robotic Hernia Center, and which is specialized in only doing that, right? So, how is it the mechanism for those patients to get from being well, trauma, open, get out of the hospital, heal, now have a massive hernia, and now there's a dichotomy, right? Because the hernia with obesity doesn't do well. And then if you try to fix a hernia with obesity, the recurrence rate is greater than 60%. So now what do we do, right? So I'm curious to see how your group, Orlando Health program, deals with that.
Right. So, as we were talking before, the Cedars app that we use, I think you guys use it too. I think it was made out of Charlotte at Carolina Medical Center. But we all of us go through that app with the patients, in clinic. Well, let me back up. So let's back up to, they have an emergent surgery. They're trauma. They have an emergent surgery. They have, as you mentioned, they have higher risk for hernia. Anybody with emergent surgery has a high risk for hernia formation, right? Just because you mentioned they're usually hypotensive, they're under resuscitate, all those things. Their nutrition is not that great because, we can't feed them during those times. So a lot of times with those, we're just trying to get some sort of tissue coverage. And honestly, in the obese, sometimes not uncommon, we will just say, look, we'll accept the hernia and we'll just do a skin only closure, which again, those of you watching, that means we don't bring the muscles together. That means we just close the skin over the intestine. So, and the reason that's important is because at about 14 days, if you have a bowel that's not covered by some sort of tissue, you have, again, increased risk for complications. Most importantly, something called a fistula, meaning a connection between the bowel and the outside world, which is a horrible complication, high morbidity and mortality with that. So a lot of times in this population, we will just say, look, we'll free up the skin. We'll close the skin. It is less than ideal. It is not standard of care, but it is standard of care in a way that it gets tissue coverage and decreases their risk for those other complications, right? And you just have to learn, I'm not going to get perfection on this one. And I'll come back and fix the hernia, to your point, Andre. So then, what they do, we usually wait minimum 6 to 8 months before we would think about tackling that hernia in somebody that had a horrific, traumatic injury. Maybe they have an ostomy as well, which adds again to the potential complication rate. So we have all that conversation with them, and we actually go through the app and tell them. Like we were just talking, I had a patient just yesterday that I said, look, your potential complication rate because of your obesity because of your diabetes, even though it's relatively controlled, it's 28%. And but yeah, right. We say, wow, you really have to educate patients because they think, oh, that means 72% chance I'm going to do great. Hey, that's not
in,
what we mean.
in medicine and
That's not what it
surgery, this does not work that way, right?
No,
It doesn't work
Right.
that way.
yeah.
Yeah.
Ghanem and I were talking. We deal with complication rates in the realm of 0.02 or 2% or less. So for us to work in the area of 28%, that's I even told a patient yesterday, it's like, if I have a consistent 28% complication rate, I won't be practicing medicine. That's not work.
You'll be in jail.
Yes. So you really have to, but again, you have to break it down for them that's, and again, I'll usually tell patients it's 28%, in general, but if it happens to you, it's 100%, right? It's 100% if it's you. So you really have to make it realistic for them because I think it's very easy for patients. I know you guys see this and you talk about all kinds of risks. And again, because we deal with such small complication rates, people are like, oh, yeah, it's just going to go fine. But you really have to make it real to them that these are the potential pitfalls of this. And with obesity, they're much higher.
Right, and this is one of the nice things of having, surgeons like yourself who do complex hernias within the same facility. Also, of having a bariatric institute, because then with somebody like yourself who is very knowledgeable about that, what you guys do is basically get the patient who has the hernia, send them to us once they're out of their critical condition. We talk to them about bariatric surgery. Oftentimes we perform the bariatric surgery, they lose weight, and then they come back to you and get that hernia repaired. And by that time, that score of complications that you mentioned, we show them that the score is going to go down, the complication risk is going to go down quite significantly after they've had the bariatric surgery. Now, there's always a caveat that now they've just had this big hernia and makes surgery, sometimes our surgery, sometimes a little bit more complex, which is why it's always better to be on top of it before such things happen. But of course, it's still doable and most of the time, and then they can still benefit from that. Rather than just go ahead and do the hernia repair, it comes back afterwards because they don't lose any weight if we don't do any bariatric surgery. And now they've had a hernia that already recurred with a foreign body as a mesh, that this is something that we use for hernias, and now it makes the surgery even more complex. It makes the recurrence rate even higher. And so it becomes this kind of vicious cycle.
Absolutely. And, it is such a benefit to have, your all service here because it is nice. I mean, I'll call both of you on occasion. Hey, can I send this person to you first? I think Andre had one. I remember that giant guy. He was tall too. I mean, he was just a big all around guy. And I think he had an emergent perforation of something that we had to fix, or hernia rib. But it is so nice to have you guys take care of that because then again we fix the hernia because as you're mentioning, to have to redo hernias, it's not just the complications of mesh, the wound complication. But every time you make you go into that fascia, you're decreasing that strength, right? It's 80. It comes back. We were always taught it's 80% of what it was. So every time you go in, you're decreasing the strength in that and increasing the risk that they're going to have just a continued problem with that.
Correct. I mean, that's why it's important, right, to have these what I call multidisciplinary teams, right? Even though we're not under the same roof, but having all of these services under one system, should I say, is easier for patient care on the long term, right? Because it's not everywhere you can just pick up the phone. Okay, you see the patient and say, hold on, let me pick up the phone. Hey, Joey, can you please see this guy for me? Blah, 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 blah. Send information. The next day, patient gets a call, go see the surgeon. So he gets everything done in a faster way, right? So, in knowing that when you are if I'm taking a patient surgery, that I need a second eye or a second opinion, or like you being an expert on hernias and resuscitation trauma, otherwise I can always pick up the phone, you come in, take a look at it and so forth. So it's always very nice, right? It's good for the patient. And the patient know that you have not just when we are operating, doesn't matter what service it's operating on that institution, that is pretty much you have every single service as a
And
backup,
we all have different tricks.
right?
Just like, I came into your room the other day. Hey, how do you expose the hiatus a little better without having to do
Correct.
something major? And that was crucial, and it was so helpful. And so it works both ways, having all these experts under, like you say, similar, kind of like one roof, but really at each other's tips, able to call each other, go into each other's ORs, and to continue to learn. And really, at the end of the day, it provides the best care for the patient, which is what
It doesn't, and this doesn't happen often because most of our, the bariatric patients, 99.9% of the patients are doing well. And but if something were to happen and they have some sort of infection of some sorts, they need ICU care. We know we have a cutting edge team that are both surgeons and ICU doctors at the same time. They have a very good experience with treating a surgical ICU patients if that is to happen, and give them the best possible outcomes. Right.
No question. And having that feedback with you guys, Andre was a resident there, so he knows what it's like. And we've actually made changes based on feedback from you guys. Made changes with our fellowship and how we round and how we manage patients. And it's only been to the improvement of patient care. So, it is a great relationship, and it's great to have all these capabilities in one system, like you mentioned.
Now,
100%.
Sorry, go ahead, Don.
No, go ahead.
No, I just wanted to ask one thing, ask Joe one thing. How was it like to have Andre as a trainee? Were you, how difficult was that?
Well, it was great, honestly, because I was new to the system. Even though I was a fellow, I came from another facility. But he had the same confidence then that he has now.
Okay, so you were lucky to not know him that well because you were new, his bottom line.
No, the difference was this. The difference was this. I think, and correct if I'm wrong, Joey. The trauma fellow, worked very close to the residents, right? And I think we were 3 residents at a time, and so it was crazy, man. It's crazy times. But the fellow was seen as an attending. So you're taking attending called trauma with us. And so the relationship was very different that we had, right? I mean, it was almost an attending to resident, but at the same time, a more collegial, right? Because you were a fellow too, right? So it was different.
The fellows here, they're right there in the thick of it too. You can go to some programs, and the fellows, as you mentioned, they're kind of junior attendings, but they almost have that 30,000 foot view, and they overlook everything, but they're not in the trenches with the residents, so to speak. They're kind of
here. You dig the trenches.
Oh man, we were right there in it with you guys. So, you just have to at a busy place like this, especially back then there were less attendings, and it was a busy time. It was a great learning experience. I mean, it's what made me a much better physician for sure.
You're going to be proud of this. So yesterday I went to see a patient as a friend of the family that was here on vacation, had a hemorrhagic brain injury, right? So he actually is an ICU doctor back at home in Brazil. So they're getting ready for him to, unfortunately, to fly back home on the air ICU thing and so forth. So he ended up getting a trach and so forth. It was a fresh trach, was very agitated him, and so he started bleeding a little bit around the trach, right? Look at that. I know how to stop it. So that kicked in. My ICU mode kicked in. So it's kind of nice.
Yes.
Right?
No, I think ICU experience makes you better, whether you do ICU or not. I mean, my intention was not even to do ICU care. My intention was just to be a general surgeon in my community. But those skills from being in the ICU, you really take them with you. And I truly approach almost every patient. I may not need all my ICU skills, but I have that checklist in my head, right? That ICU checklist of, am I checking every system? Am I doing all these things? And again, the majority of patients you don't need it on, especially on the regular floor patients, but it makes you better.
Yeah, all of us, right? We have this of our own specialty. We have this checklist in our head, right? So you already kind of have the algorithm in your head, and then once that stops, then your second algorithm kicks in, which is your general surgery / trauma that you learn, right? Start kicking in. It's very interesting, right? Because even though you haven't done trauma in so long, but I mean, it kicks in. It's crazy. I mean, it just kicks in and you do it like, like Gunna, same thing, right? I mean, I bet the same thing for him because he's a different experience than me and you, Joey. As you know, I mean, Gunna had the experience of surgery training in Israel and then one here in America. So he has a very different, sometimes different algorithm in his head by experience only, right? So sometimes he can do some diagnosis, doesn't even need images or anything like that because it's done back at home. He was done that way, and then he already knows,
Right. And
right?
once
The only thing he doesn't know,
you've done things.
what's behind his doors, right? Behind those doors, he has no clue what's going on
Right.
in there.
Once you've done something for so long, it doesn't matter if you've been out of training 10 years or so, it's always going to kick into you as second nature. But yeah, definitely, being exposed to all of these things give you a different perspective on things for sure.
Right. In trauma, I had a really good attending where I trained in Tennessee, and he was from Ecuador, and so he, again, like you, Ghanem, he didn't have all these other tools. He had to really rely on physical exam, but he never carried a stethoscope either, which was amazing. He would listen to the ones. He'd put their hands on the back. He'd be like, "Oh, he's got crepit." I'm like, "How did you even hear that?" But anyway, he would always say, "You don't have to be a trauma trained surgeon to do trauma. You just have to be a good general surgeon, right? And use good general surgery skills and principles, and you can take good care of patients." So I think that's what all of us fortunately have that background in.
So listen, Joey, we want to thank you very much. I know you're post call, so I know you're really ready to enjoy your family. You have a new baby, which is awesome. So thank you very much to participate with us here. It's always good to learn different new things and catch up. Gunnar, do you want to say
No,
anything?
absolutely. Thank you for giving us the time. I know we stole you from your family now in this post-call time, which is something that you as trauma surgeons look for. I want to say that I'm also grateful that I'm not a trauma surgeon because I don't have to spend 26 hours at the hospital in a row. That is something
Boom,
that I
just like
don't
that.
miss. But
Yes.
we appreciate you, and we appreciate, of course, all of the wonderful care that you give in this lovely level 1 trauma center that you and your colleagues have built and continue to service to this community.
Definitely, the feeling is mutual, guys. You guys bring so much to the table, and you're always on the cutting edge. I mean, I've used you guys. I mean, Ghanem, you recommended this new procedure so I could get the manometry that for these patients, and then Andre, obviously, you've helped me get it done, and I've got one more tomorrow. So, no, you guys are always cutting edge, and I really appreciate what you bring, and appreciate you letting me just participate. Glad to be part of this platform, and great to see you guys be so successful.